Let's talk about myomectomy from Telinde. What are the indication for myomectomy? First, that those symptoms that interfere with the quality of life, that is abnormal uterine bleeding, urinary or urinary symptom, pelvic pressure or pelvic pain, or asymptomatic women, those who are infertility or recurrent pregnancy loss history. After you have to evaluating the other causes, cavity distorting fibroid, previous any adverse pregnancy outcome. This is the classification system. Now these three is in contact endometrium mucosal 0, 1, 2, 3. Pedunculated 0, intracavitary. 1 is less than 50% intramural. 2 is more than equal to 50% intramural. 3 is contact endometrium 100% intramural. 4 is intramural. 5 is subserosal more than 50% intramural. 6 subserosal. This classification 2 to 5 subhybrid. When a patient, usually when they are presenting with abnormal uterine bleeding, it is important to exclude the endometrial pathology, which is endometrial cancer, complex endometrial hyperplasia with tevia, and endometrial biopsy should be far from. Anemia is common in women with heavy menstrual bleeding, that should be assessed. Thyroid disease, it may be a cause of heavy menstrual bleeding, that should be ruled out by doing TSH. Investigation for hematological causes of heavy menstrual bleeding should always be considered in women with leiomyoma. Okay. Then the concern that marcellation may lead to the spread of an occult uterine sarcoma at the time of tissue extraction of presumed uterine leiomyoma has led to an attempt to increase the recognition of the importance of identifying malignant uterine disease before surgery. But the uterine cancer is very less, 1 in 2 to 580 women. Most unfortunately, the most preoperative assessment cannot completely exclude the possibility of leiomyoma sarcoma. The endometrial adenocarcinoma is the most common malignancy observed in women fibroid with abnormal uterine bleeding. So endometrial biopsy has to be done. Okay. Then what are the indications of surgical myomectomy? The main indication for surgical myomectomy is to control symptoms that impair the quality of life, like the pressure symptom, pain symptom, they recur future fertility, complete. If they complete childbearing, hysterectomies can be considered. Okay. Then if they know myomectomy is also a treatment option, those who are already completed their family but they desire to keep their uterus, you can offer them. And that marcellation, dissemination of occult uterine sarcoma can be occur. No specific uterine size require intervention who are asymptomatic. Surgery is not indicated. Prophylactic symptom prevention, as there is no reliable predictor symptom development. Then another potential indicate for surgery is asymptomatic women in the presence of moderate to severe hydronephrosis from ureteral compression. Surgery in asymptomatic patient with moderate to severe hydronephrosis from ureteral compression. Surgery intervention is not indicated solely to exclude the possibility of sarcoma. In postmenopausal women, if it is rapidly growing tumor, the probability that mass is malignant. In this situation, myomectomy is not recommended. The patient should refer to a gyneco-oncologist for investigation and potential hysterectomy. There is an association of intracavitary cavity distorted myomectomy, infertility, and recurrent pregnancy loss. However, it is not clear that after removal, the reproductive outcome will increase. That is no evidence. Surgery can be considered in women with submucosal cavity distorting fibroid, investigating other cause of fertility, recurrent pregnancy loss. Okay, then how we preoperatively optimization. Prior to surgery, important to optimize the patient medical condition, specifically in relation to the anemia. We recommend a complete blood count, possible iron study, exclusion of sickle cell or other hemoglobinopathy. Preoperative anemia from chronic bloodless is associated with increased postoperative morbidity and mortality. So you should correct the anemia rather than transfusion. Either you can supplement oral iron, vitamin C, or enhanced observation can hemoglobin by 2 gram per dl within 2 to 3 weeks. If bleeding is controlled, then the rate of increase is 2 gram per deciliter in 2 to 3 weeks of oral iron therapy, or you can advise IV iron may be necessary for to improve preoperative hemoglobin. Okay, these are the pre-operative medical measure to reduce the intraoperative blood loss. If you are using the intramyometral vasopressin, the rate of blood loss is reduction of blood loss is 245 ml. If you are using the intramyometral bupivacaine or epinephrine, it will reduce the blood loss 60 ml. Or you can use the vaginal misoprostol 97 ml, vaginal dinoprostol 130 ml, 31 ml, gelatin thrombin matrix, fibrin gelatin patch, IV ascorbic acid or intravenous tranexamic acid. In a Cochrane review also, there is the role of GNH agonist treatment before myomectomy. You can give 3 to 4 months prior the myomectomy surgery to significant positive impact on the preoperative hemoglobin by reducing the abnormal uterine bleeding and reducing the size of the myomectomy, and volume change, reduce the volume change of the fibroid within 2 to 3 months of the treatment. The usual preoperative GNH agonist small statistically significant reduction in the intraoperative blood loss by reducing the size and vascularity. However, there is no difference in transmission rate. In addition, the preoperative GNS agonist decrease the uterine size. The therapy may allow surgeon to open procedure, because if it will reduce the size, you can go for a open procedure with a transverse incision rather than a, because if it is size decrease, so you can no need of vertical incision, you can do with a transverse incision. However, GNS agonists do cause side effect like hot flashes, may also decrease the size of the small myoma to a level that may not be observed at the time of surgery. What happens? The smaller size of the fibroid, that will be becomes so small, it will difficult to detect during the surgery. So this small fibroid, small myoma will be recurrent at the post-operative period after some 6 months or 1 year after that. Such myoma may then regrow post-operatively after return to normal menstrual function. It is not generally recommended to use GnRH agonist pre-treatment only to decrease the intraoperative blood loss, but it may advantage correct the preoperative anemia. Another evaluation may you do blood type screen, possible cross match blood urine pregnancy test to rule out pregnancy before surgery. Intraoperative blood salvage technique useful to decrease the operative blood loss. What are the principle to what are the various principle to decrease blood loss at myomectomy? Uh, First is most clinical trials on the laparoscopy surgery decrease the blood loss compared to the open surgery. The possibly medical intervention that can reduce the blood loss by myomectomy. Combination of these intervention like intramyometral vasopressin or plus vaginal or rectal misoprostol may be an additive effect. The use of mechanical tourniquet to occlude the uterine blood supply at the laparoscopic through when you are doing the laparoscopy procedure, that in that time you have to do tourniquet can be applied to the uterine uterine vessels, and that will decrease the blood loss. This different approach, how we will do, use a Foley's catheter, tie around the cervix, or placement of polygalactin suture around the both cervix, or this suture material can be tied with the infundibulopelvic ligament. Both uterine and ovarian vessel can be occluded, and you can do easily. The loop of ligation basal in the myoma, a loop of ligation in the basal of the, you can do the ligation of the basal of the myoma pseudocapsule, that also decrease the blood loss, but has not proven reduced transfusion rate. Because of the challenge, if you are doing a robotic surgery, the vascular clamp, there is difficulty to that robotic in during robotic or laparoscopic surgery doing that tourniquet clamp. So you can apply the vascular clamp like bulldoze clamp that fit through the trocar, can be used to the uterine artery temporarily. Then the another method to reduce the blood loss, you can use without instead of using the bipolar and monopolar cautery, you can use the ultrasonic device rather than a electrosurgical device to reduce the blood loss by 50 to 60 ml. The unidirectional and bidirectional barb suture can be that also barb suture, because you have to the you no need to like prick so many times, only one prick, and there is no need of tie the suture. The barb suture can decrease the blood loss at the laparoscopy and robotic myomectomy, as well as decrease the operative time while suture, because during laparoscopy the suturing technique is also challenging. So if you are using this barb sutures or barb suture, that will be helpful easily, it can be easily applied. Then Uh, Hysteroscopic approach to myomectomy. Hysteroscopic myomectomy is a minimally invasive transcervical transcervical procedure performed under direct visualization and constant visual control of the removal of intracavitary and submucosal leiomyoma. This approach provide an alternative to hysterectomy for the treatment of abnormal uterine bleeding. Approximately 40% women with abnormal uterine bleeding will present with intracavitary lesion. Hysteroscopic approach to myomectomy. Okay. Hysteroscopic myomectomy is minimally invasive transcervical procedure performed under direct visualization. You will, by direct visualization and constant visual control for removal of intracavitary and submucosal. This can be used for type 0 and type 1. This approach provides alternative to hysterectomy for the treatment of abnormal uterine bleeding to endoluminal leiomyoma. This have infertility, experience recurrent pregnancy loss, suffer from leukorrhea, dysmenorrhea. Those who have failed medical therapy, you can offer them a hysteroscopic myomectomy. In these cases, those cases, surgical intervention to intracavitary ligament solution for those patients, those have infertility history, experience recurrent pregnancy loss, and suffer from a leukorrhea because of discharge, because of that intracavitary leiomyoma become degenerative changes that lead to persistent discharge, leukorrhea, and dysmenorrhea because of the intracavitary leiomyoma trying to during each uterine contraction, it trying to come out of the uterus. For those who have failed medical therapy, you can give them option for hysteroscopic myomectomy. How to prepare the patient during for hysteroscopic myomectomy? The hysteroscopic myomectomy may be a complex procedure requiring excellent manual dexterity and advanced skill. The goal is, what is the goal? To minimize the incomplete resection. This is the main goal, is you have to minimize, don't leave some part, you have to remove completely, minimize the incomplete resection. Regrowth, recurrence has to be prevent, complication has to be, these are the goals, has to be minimized. The regrowth has to be minimized, the recurrence has to be minimized, the complication has to be minimized. Okay. Most of the submucosal fibroids that occur at the scaphoidal site, but they may occur at the other side also, that is carpal fundal, scarnum, posterior and anterior lateral surface. There may require unique procedure. The most sensitive diagnostic stage to evaluate the endometrial cavity prior to hysteroscopic myomectomy is that you have to do a diagnostic office hysteroscopy before you going for hysteroscopic myomectomy, and saline infusion sonography to properly map the fibroid size and the location, and the depth of the like type of fibroid, type 0. If it is type 0, it is completely intracavitary. If it is type 1, is like less than 50%, less than 50% intramyometrial and more than 50% less than, okay, less than 50% intramyometrial, more than 50% intracavitary, and type 2 is more than 50% intramyometrial. MRI can be considered in women with uterine enlargement. If your uterus is enlarged greater than 12 to 14 weeks of pregnancy, you can offer a MRI. MRI indication of MRI for fiber mapping is that one indication where the uterus size is more than 12 to 14 week size. Another indication is if you are doing an ultrasound and there is a technical difficulty because of obesity and uterine position and inability to distance the cavity and multiple uterine fibroids, then in that case you can offer a MRI to do the size, location, number, depth of the penetration of the intracavitary leiomyoma. All these things has to be noted before you are proper planning to hysteroscopic myomectomy. And the important determinant for the safety and feasibility is the myometrial margin. There has to be some margin left behind, otherwise you can't do perforation. So this can be evaluated by saline infusion sonography or MRI. Although uterine remodeling during operative stage is important, 1 cm margin from the lesion to the serous surface. Okay. Then ESGA classifications. Already I told that like endometrial cavity protrusion size leiomyoma. If you complete resection expected 90 to 60 type 0 type, there will be chances is 96 to 97%. If it is type 1, that is less than 50% intramyometrial. There is chances of complete resection is 86 to 90%. If it is type 2, 61 to 83%. Additionally, the amount of fluid absorption can also predicted by the free effort degree of if the degree of involvement and the duration of surgery, that will determine the how much fluid absorption take place during the surgery. Type 0, already told, type 0 myoma is totally intercavitary, and it is usually easily removed. Even some type 0 myoma cannot be removed hysteroscopically, such as those size is more than 7 centimeter. On a 3 centimeter are able to additional fibroid surgery 90% of the time. 4 centimeter who require 60% of the time. Okay. Removal of the myoma, deep myometal involved type 1 or type 2. The diameter greater than say advanced hysteroscopic skill is required. 4 to 5 centimeter removed hysteroscopic experienced surgeon. Additional surgeon may wish to provide informed consent 2 stays. It is 2 stays hysteroscopic surgery patient had large fibroid type 1 type 2. If more than 4 to 6 centimeter, there will be a data demonstrated in case recovery complication in resection on the fibroid greater than 3 centimeter. Surgeons should consider always need a pharmacology consider decrease the size of myoma. Yeah, I already told you can give a GNRH and agonist to decrease the size, and SPRM selective progesterone receptor modulator to decrease the size of the fibroid before surgery 3 to 4 months prior the planning of the operations. Okay, this is the European Society of Hysteroscopic classification of the submucosal myoma. The type 0 is fibroid complete in the endometrial cavity, so intercavitary. Intramural is but component intramural, but more than 50% in the located in the endometrial cavity. Intramural component less than 50% in the intercavitary compartment. This is the image showing the myoma figure 0 type 0. An example, a woman doesn't have boil symptom but bleeding attributed to intercavitary lesions. She may benefit from isolated removal of the. If she doesn't have any symptom, any bulk symptom, any pressure symptom, but only that she has bleeding, she has complaining of bleeding attributed to the intercavitary lesion, she may benefit from the isolated removal of intercavitary myoma even if other myoma are present. General principle. What is the principle of hysteroscopic myomectomy? The first principle, there should be a continuous intrauterine distension should be required for operative hysteroscopy. Generally, you have the lowest intrauterine pressure, that is 70 to 75 to 100 mmHg. However, higher pressure is needed if the uterus size exceeds more than 12 to 14 weeks of pregnancy. Usually, there will be a pressure is 75 to 100 mmHg. If higher pressure may be needed when the uterine size is more than 12 to 14 weeks. Okay, when there are multiple intramural fibroid and fibroid greater than 4 centimeter. These are the condition where you have to increase the pressure from 75 to 100 is the normal pressure. Lowest intrauterine pressure you have to increase to the highest if its size is more than 12 to 14 week size, uterus size, and the multiple intramural fibroid and fibroid size is more than 4 centimeter. Then another things is the fluid used for uterine distension, ionic or non-ionic, by a continuous fluid management system during operative hysteroscopy. The characteristic of ideal fluid management include the instant determinants of fluid deficit. You should alert regarding the fluid deficit should not be increased. The amount of fluid absorption depends on the length and complexity, duration of the surgery, the complexity of the tumors. Always you have to a pre-operative evaluation like cardiac, renal, and pulmonary status of the patient must be known and assessed before the operative cystoscopy. Otherwise, if she cardiac compromise because of fluid overload, renal, pulmonary edema, patient with compromised cardiopulmonary renal function, they may tolerate only small volume of intravascular fluid absorption. So it will be difficult if you are not doing a proper pre-op evaluation like cardiac function test, cardiac echo, renal, pulmonary status of the patient before doing this operative hysteroscopy. Okay. Then during hysteroscopy surgery, the gynecologist must be provide frequent feedback to the anesthetist regarding the fluid deficit. How much blood loss, how much the fluid deficit, everything has to be told to the anesthetist. How much the blood loss, type of the fluid use, The anesthesiologist should inform the surgeon if clinically significant. Always use told that anesthesiology that if you suspecting some hemodynamic changes, if you are suspecting hemodynamic changes like oxygen saturation decrease, end tidal CO2 level increase, long sounds, vital signs, mean arterial pressure, cardiac arrhythmia is there, then suddenly you have to stop this procedure until the hemodynamic changes result and determination is made whether surgery should proceed or not proceed, whether stop, that will be depend on the patient hemodynamic conditions. Then blood loss usually nominal during operative hysteroscopy, while informed consent for blood transfusion should be obtained. It is rarely needed, but you should take the consent beforehand. Then operative hysteroscopy surgery should not be performed in a patient who had what are the contraindication. You should not do in this patient. You should not do a operative hysteroscopy, because if you are doing hysteroscopy, there will you infuse the fluid that will disseminate the disease. Okay, what are the condition? Like you should not give do operative hysteroscopy. Like if she had a active, this point is important, active. No, see if she had a previous HOPID, that is not a contraindication. If she had active PID, that will be a contraindication. If she having fever, TO ovarian abscess, hydrosalpinx, that toxic fluid, again go to the peritoneum and peritonitis. The active prodromal orifice infections, cervical cancers, confirmed viable intrauterine pregnancy. These are the contraindication for operative hysteroscopy. Should not be performed in patient who has active PID, fever, TO ovarian abscess, hydrosalpinx, active or prodromal orifice infection, cervical cancer, confirmed viable intrauterine pregnancy. Rarely some medical comorbidity condition also contraindicated for hysteroscopy surgery. However, preoperative consultation like anesthesiologist, cardiologist, nephrologist, pulmonologist, they will give a clearance that may be beneficial, preferring the patient for. In reproductive age women, operative hysteroscopy is typical time with then the time when you should do this procedure. The timing must be individualized. The surgery during early, if you doing the surgery early proliferative phase, it much easier, because already there will be a thinner endometrium, lesser tissue debris, because already that menstrual blood already it is come out beforehand, because early proliferative phase. So there will be less tissue debris, thinner endometrium, easier view blood compared with surgery during the secretory phase. But in secretory phase there will be already thick in endometrium, it will difficult to and it is difficult to see that view. Then again, women with prolonged anovulatory cycles, if they have a prolonged anovulatory, suddenly they may copious bleeding, fragile, exaggerated proliferative endometrium that may bleed during this operative hysteroscopy. So you should not do. You should always do in early proliferative phase. It is better to view thinner endometrium, less debris, less bloody field. But if you are doing in the secretory phase, there will be more bloody field, thicker endometrium. And if you suppose a patient has prolonged anovulatory cycle, suddenly already she has prolonged anovulatory cycle, the fragile endometrium, suddenly at any point of time it can bleed, and fragile exaggerated proliferative bleed easily during the operative, so should not be doing the respiratory. So how to prevent this? If you suspecting it is an anovulatory cycle leading to unsatisfactory visualization, hysteroscopy resection may create abundant tissue debris. Unsatisfactory visualization that require use more hysteroscopy. If you field is obscure, then it will require more fluid, more hysteroscopic fluid, increase the duration of the surgery. Then in those patient with an anovulatory cycle, what you will do, you can advise a progesterone supplementation, preoperatively progesterone therapy to luteinize the endometrium. Then once the progesterone therapy is withdrawn, then again it will be menses. Surgery can then be performed. You preoperatively, then where we have, if patient has anovulatory cycle, you will give preoperative progesterone therapy. Then you after some days you withdraw the progesterone, that will mens will happen. Then surgery, after that surgery can be started. In addition, some patients with ovulatory, with those have ovulatory cycle but they have been heavy menses, then in that cases you can give going some difficulty, make it difficult impossible. So early proliferative phase is general Surgery should not be cancelled because of bleeding. Okay. Then these are the things. Then how we prepare for the cervical preparation? Then cervical preparation, how will prepare cervical preparation? This is the cervical preparation. Cervical preparation means okay. Cervical preparation. Cervical preparation means the hysteroscope should be enter easily without any obstruction. So what you will do, you can use osmotic dilator to dilate the cervix, estrogen therapy, GnRS therapy, selective progesterone modulator, antiprogesterone, misoprostol has a elective conflicting result. So there is a debate. The benefit of misoprostol approach is to variable. So but they recommended to use the misoprostol before all operative hysteroscopy, myomectomy procedure, unless there is a contraindication for interest. To soften the cervix, that facilitate you can dilate the complete hysteroscopy removal of every cervical dilatation. Because misoprostol soften the cervix, cervical dilatation is easier. The risk of uterine perforation, cervical laceration is decreased. The side effect of preoperative if you are giving preoperative misoprostol, what are the side effects? First one is the pyrexia, nausea, bloating, cramping, diarrhea, self-limited. What will give acetaminophen, a non-steroidal inflammatory agent only, nothing to do. Then another blood to reduce the preoperative blood loss, you have to use diluted vasopressin. How to dilute? While performing the progesterone to decrease the risk of hysteroscopic fluid absorption, facilitate the cervical dilatation, decrease uterine bleeding. 20 units, you have to take 20 unit, 1 ampule, 20 unit in 200 ml normal saline. It has to be injected into the cervical stroma. 5 ml has to liquids 1 cm depth at the 11 o'clock position and 2 o'clock position, and 5 and 7 o'clock position you have to introduce into the cervical stroma. Then always tell this before you inject the vasopressin, you have to told your anesthetist, and hemodynamic and cardiac stability must be confirmed with the anesthetic before intracervical injection. And the vasopressin should be aspirated while you are injected. You should always inject very slowly over 2 to 3 minutes into the cervical stroma. If blood is aspirated, don't inject the rest amount in that position, should not be made in that position, and you should remove, rather than syringe should be removed, another intracervical stroma location attempted. Then vital sign, like what are the signs you should look for during the vasopressin injection? Bradycardia, cardiac arrhythmia, hypertension, sudden collapse because of vasopressin last about 20 to 30 minutes. They have to monitor these things: bradycardia, arrhythmia, hypertension. If surgery is prolonged, bleeding increases, additional vasopressin can be required. Then instrumentation. There is two type of methods, two hysteroscopy method used to remove the uterine fibroid. One is the operative hysteroscope, another one is the your hysteroscopic tissue removal operative. Use the operative resectoscope. Two hysteroscopic method. There are two hysteroscopic method. Remove historically the use of operative resectoscope. With past decade, HRT become available. Currently, continuous visual intercavitalization, pathological tissue data control. Okay. Previously, all the procedure they are doing with the monopolar cutting. Currently, they are using the bipolar because of safety. Improve safety parameter. Because if you are using the monopolar resectoscope are available, still some are using. During using monopolar resectoscope, you should, but the limitations of the technique regarding the, you should consider about the fluid medium. If you are use the monopolar device, the requiring non-conductive, you have to use a non-conductive fluid media like non-conductive fluid like glycerin, monopolar glycerin. Okay. The fluid media, monopolar device require non-conductive fluid media to complete the electric circuit between the active electrode and the dispersive electrode. If you are using cyanide inadvertently, this cyanide disperses the current, prevent clotting, coagulation of the tissue. However, steroid cannot use because it will cause hemolysis. Therefore, monoclonal effective addition solute may be added like glycerin, sorbitol, glycine, sorbitol, mannitols to make the fluid non-conductive and decrease the risk of hemolysis, increase osmolality of the fluid. Okay. Then another things, observation of, if you are observed large amount of fluid, prolonged duration surgery, you are giving more amount of fluid, there is fluid deficit, can be associated with hyponatremia, nausea, vomiting, neurological symptom including seizure, muscular cramp, twitching, coma. Okay, these are the complications you have to look into it. Then bipolar technologies can be used. In this, you can use a saline as the distension media. Saline, there is a conductive media, saline. Saline is isotonic, so it is electrolyte solutions. Whereas the current hysteroscopic guideline, electrolyte disturbance doesn't occur. Because it is an isotonic solution, there will be no electrolyte imbalance. But there will be a fluid overload that can occur, cannot be used with monoclonal. Use a fluid management system, important for patient safety. So you have to, the important things has to, fluid deficit has to be calculated. Improve the patient outcome. The ability to vary intermittent pressure, ability to vary intermittent pressure above below MR facilitate the complete fibroid excision. What happen if you initially you have to see the, you have to tell your anesthetist calculate the main arterial pressure, and you have to set your your hysteroscopic pressure above that. If you make that above the main arterial pressure of the patient, then it will be act as a tamponade effect, and it will help to remove the complete MAF above or below the MAF. It will help facilitate the complete fibroid excision. At the beginning of the surgery, the anesthetist can calculate the MAF to determine the initial hysteroscopic intermittent pressure. The surgical team should set a fluid management system to predetermine fluid deficit. Fluid management to surgical team has to should then set the fluid management system, predetermined fluid deficit based on the solution used, medical history. Surgeon can dilate the cervix using Hager's dilated using half size if necessary. Okay. Then varying intermittent pressure during the procedure decrease the risk of encountering false negative view of the uterine cavity. So with high pressure, fibroid may be compressed to the myometrium, creating sinking of air. This may reduce likelihood that fibroid is recognized and exercise, leading to perception of recurrence. Okay, what happened? You were giving bearing, you were making the intermittent pressure during the procedure, that will decrease the encounter of false negative view. So with a so the pressure has to be maintained. The main aim is the pressure has to be maintained to see the fibroid properly. If your fibroid, if varying interval, there will be decrease the risk of false negative. There should be, the pressure should not be so high, should not be so low. So it should be vary. If you vary the intermittent pressure, there will be decrease the risk of recurrence of false negative view. If you are so much high pressure, there will be compressed the fibroid may be compressed into the myometrium, creating a sinking of fibroid. This may reduce the likelihood of that fibroid is not able to recognize it. So reduce the likelihood of the fibroid is recognized, excised, leading to partial recurrence. That will lead to recurrence because the fibroid sinking inside the myometrium, you are unable to find out because of high pressure. So it will be found in later stage at a recurrence. So then, when bleeding obscure the surgical site, what are the measures you should take? If you are getting your surgical field is obscure, so you have to, a temporary measure can be done by increase the intermittent pressure, that will act as a tamponade effect with the endometrium and myometrial arterioles. Okay. Excellent fluid measurement, collection, drain fluid is essential. Another things, you should collect the fluid, extra fluid, and how much fluid go inside, how much fluid come out. The fluid deficit has to be calculated. How will calculate? The two item require special recognition. First, use a adherent perineal funnel drape to collect the outflow of the hysteroscopic fluid. You have to you use a adherent perineal drape to collect the outflow from the hysteroscope. Okay, this is the fluid that will collect in the perineal drape from the hysteroscope. Tubing is then attached to the collection canister to calculate the fluid deficit. Collect to the collected canister to calculate the fluid deficit. Second, a poodle bag, a single-use disposable fluid aspirate that quickly remove the fluid from the operating room. Can be moved manually. Okay. Then operative approach with electric surgical device. Okay. The degree. Urology resectoscope, a monopolar loop to perform the fast hysteroscopic myomectomy. Was done the fast hysteroscopic myomectomy, New Earth and mean. In contemporary practice, many surgical manufacture company provide operative hysteroscopic device. First one is your hysteroscopic operative hysteroscope. Second is electrosurgical device. Operation done by several components, including the outer sheath, the surround the recircular fluid channel of the telescope. Operative hysteroscope can perform with the 0-degree telescope with a slightly forward oblique 12 to 30-degree telescope. This telescope with outer diameter 3 to 4 mm, internal and external sheath diameter is 13 to 31 French. The size of the wire loop determines the amount of tissue fragment chips that will be resected with each passage of loop through the firewall. Operative contain working element with the wire thermal loop, cutting knife, cold loop, vaporizing electrode, including valves and barrels. Operative resectoscope containing working element. This I have read already. The outflow channel for the removal of bloody fluid tissue debris, providing a continuous clear visualization. The outflow channel, what is the function of the outflow channel? It will remove the bloody fluids and tissue debris and provide a continuous clear drainage system, clear visualization of the endometrial cavity. Further, an element connects the instrument to the electrosurgical generator to activate electrical energy with the foot pedal control, cutting and tissue ablation. These are the instruments. The first one is the three sizes. This all are the bipolar generator, 3 bipolar hysteroscope. This is obturator wire loop. This is the obturator wire loop. This is the outer sheath. This is the obturator. This is the wire loop. This is the outer sheath. This is the inner sheath. Inner sheath. Then working channel. The hysteroscoping slicing resection technique is using require repeated progressive passage of activated wire loop that maintains contact with the fibroid. Always remember the wire loop should be placed behind the lesion and the loop is activated by the foot pedal. Movement is always from cephalate to caudal, permit continuous visualization of the air loop and decrease the risk of perforation. Okay, remember this technique, slicing resection technique, and your wire loop should be placed behind the fibroid and the loop is activated by the foot pedal and the loop is always, the movement of the loop is from cephalate to caudal, that is permit continuous visualization of the wire loop as well as decrease the risk of uterine perforation. If you adequately listen the uterine cavity, is necessary to have the hysteroscopy is advanced when the tissue being resected. Care must be taken to resect the lesion at the fundus. Remember, while you are doing the resection at the fundus and near the tubal ostia, these 2 points are very thin. So thinnest region within the endometrial cavity. So be careful at this point. One is fundus and tubal ostia. Okay. Then an advantage of bipolar buses. What is the advantage of bipolar? If you are using a bipolar electric current without tissue contact, you can activate without any tissue contact. Additionally, the tissue adherence to the loop will reduce with bipolar. After the fibroid is caught, tissue fragment will accumulate and float within the uterine cavity. What is the advantages of bipolar is the tissue is not adherent to the wire loop. Okay, and the tissue is floated into the endometrial cavity, uterine cavity. And without any tissue contact, the electrical energy can be generated. In general, resection continue until the tissue fragment is begin to obscure the view. You have to doing till you have a obscure view with all the tissue fragment. The tissue fragment can be retrieved by under direct visualization with the wire loop, or if you are doing with the wire loop, you can bring it out with the help of wire loop, or blindly with a polyp or uterine forceps or irrigated out under direct visualization through the endocervical canal into the vagina and collected. This preferred technique is to remove the tissue fragment under the direct visualization with the wire loop and allow fragment fall out to the cervix while slowly remove the hysteroscope. Surgeons should continue to slice the myoma until the what is the point of ultimate point, the last point where we have to stop? When you saw the pink fasciculate mymetrial fiber, this is the last, the ultimate end point of doing resection. Pink fasciculate mymetrial fiber noted and the hold appearance of the fibroid is absent. These things as to the end point of the slicing. This can be achieved by separating the slender connective tissue that bridges the fibroid to the adjacent myometrium. The use of electric energy should be minimized. The pink fascicle is seen to prevent further resection of myometrial tissue, as would increase fluid absorption and bleeding. All tissue fragments should be seen pathology for histological evaluation and to wait. If tissue fragment is retained in the uterus, the patient may experience after that leukorrhea, colicky pain, intrauterine infection, or prolonged serosanguinous discharge. Incomplete resection may result in persistent of symptoms. Okay, which grasping first way we have to use and remove the care must be taken while because the perform blindly. Which have myometrial penetration. The main objective to separate the fibroid from the pseudo capsule, intermediate uterine decompression, allow progressive protrusion of the intramural component to the cavity. So the main objective is to separate the fibroid from its capsule, pseudo capsule. If you are giving intermittent uterine decompression, you increase pressure, decrease pressure, increase pressure, that intermittent uterine decompression, that will allow the progressive protrusion of the intramural component of the fibroid into the cavity. That progressive resection can then occur. This refer rather than resecting within the myometrium. So always do a intermittent uterine decompression that will allows the progressive protrusion of the intramural component of the component of the fibroid. This progressive resection will be better than doing a resection by going inside the myometrium. Will be dangerous. That little perforation. You can see here the post-hysteroscopic resection view of the complete fibroid removal, post-uterine wall. B point, this you can see the all the pink myometrial fasciculate myometrial pink fiber are seen. Remember, okay. Close off the view. To aid allowing protrusion of the intramural component, type 1, type 2. The technique is hydromassage. This technique is called as hydromassage can be used. This require automatic fluid managing system, rapid change in intrauterine pressure. How we will do this hydromassage? If you are going the intrauterine, changing the intrauterine pressure, that will lead to hydromassage. This achieved by starting the fluid as well as periodical remove the hysteroscope, the endometrial cavity. How will rapidly change the intrauterine pressure? This by you can stop the fluid channel or suddenly start the fluid channel, or periodically you should remove again the hysteroscope and again enter. This technique increase the myometrial contraction. How this technique increase the myometrial contraction and facilitate the migration of the intramural component into the uterine cavity. In patients with particularly large myoma, large cavity, manual massages can be performed by placing a finger into the uterus, like obstetric maneuver, massaging endocavity to help the expel of the fibroid into the cavity, or else you can do the manual massage to manual massage, like doing the postpartum hemorrhage can be performed placing the finger into the uterus and endocavity help the expel into the fibroid into the uterine cavity. And the resection of type 2 lemma volumetrically significant portion of the lemma retained within the myometrium. If the remaining portion is more intramyometrial than intercavitary, further attempt at a second stage. If it is very big inside into the myometrium, so much intramyometrial component, so you can do in the same staging, same sitting, so you have to ask her to comment the second stage for his resection may be incomplete. Therefore, post-operative evaluation with saline infusion sonography is recommended. So always do a post-operative evaluation with a saline infusion sonogram prior to attempt a second hysteroscopy procedure to confirm the size and relative location of the remaining fibroid. Informed consent to take in the possibility incomplete excision need for additional procedure. Okay. Then deeper lesion type 1, type 2 lemma may be with the resection technology. However, the learning curve may be longer operative sector versus hysteroscopic tissue removal system. Increase surgical volume, the use of training, remulator, surgical acumen, allowing surgeon to approach retrieval large myoma, fluid management with monopolar. Hysteroscopic myomectomy is especially critical because monopolar is why it is critical. Monopolar, I already told, if you are doing with monopolar cautery, you have to glycine, sorbitol, mannitol, all these are hypotonic solutions. Hypertonic solution you can taking inside hyper that will lead to fluid imbalance. This technique removes non-ionic fluids such as 1.5% glycine, 3% sorbitol, 5% mannitol. The risk of hyponatremia increases with fluid deficit. With this hyposmolar fluid medium, many surgeons feel uncomfortable continue their percent fluid deficit greater than 750. However, if intraoperative serum electrolyte are normal, surgery proceed until the fluid deficit reach 150 ml. Surgery should be stopped at deficit of 1.5 liter due to the risk of precipitous drop in serum sodium. When you stop, if you are using glycine, sorbitol, mannitol, you stop at 1.5 liter. Okay, if the normal. The length of surgery as well depth of penetration of lymphoma depth of the amount of fluid absorption. Therefore, the larger lymphoma may not be fully excised before this limit is reached. Increased probability incomplete dissection persists. Operative hysteroscope with vaporization. Vaporization of fibroid may be performed with spherical cylindrical electrode that are dragged along the surface of the limb. Bipolar monopolar hysteroscopy device has been electrically vaporizing ball barrels that vaporize the myoma without tissue analysis. There may be spherical cylindrical have multi-dented surface. This design functions like array electrode when used in high cutting vaporized tissue quickly without generating fragment. In most cases, the hysteroscope doesn't need to be removed. Instead, the current should be applied when the electrode is contacted the tissue. The electrode should be moved slowly. The degree of vaporization depends on the contact of the fibroid, voltage, duration, contact, resistance. Low voltage current with high power, the interpolation should be hysteroscopic marcellator. The mechanical method to remove the aspirate tissue. Associated production few tissue fragment, fewer insertion of the usual saline distance and media. For women in cervical stenosis, markedly retroverted retroflex menopausal status, small uterine cavity, tissue retrieval system are additional 30 minutes. Hysteroscopic tissue removal system, those who have cervical stenosis, markedly retroverted retroflex uterus, menopausal status, is a respiratory, there is a respiratory for the patient population. Usually visual direct cavities of the normal cavity. What are the post-operative recommendations we will give to the patient? Operative hysteroscope is generally performed in the ambulatory setting. Generally, the procedure is a OPD procedure. Under the sedation, intravenousal sedation or paracervical block you can give. With a small caliber operative hysteroscope, cooperative patient, small type 0 glioma, the some surgeon treating fibroid in the office in the normal anesthesia. Typically, operative hysteroscope is safe, effective, associated with few immediate complications. Patient should expect spotting, bleeding 2 to 4 weeks following the procedure. If the procedure is found in the late proliferative phase, secreted phase, there will be a bleeding following the day. Procedure may stop, then followed by another menses going to the menstrual cycle. This can be annoying to the frustrating to the patient, but is normal. Likewise, patient treated with progesterone, if he is treated with progesterone before surgery, who are asked to discontinue the progesterone therapy after the procedure, then may experience hormonal vagal bleeding. Additionally, if progesterone injector device is placed at the completion the surgery, may patients breakthrough bleeding. Okay, this thing has to be post-operatively has to be explained. Following surgery, patient may use tampon, pad, menstrual hygiene, vaginal intercourse may be resumed within 7 days after the procedure. Touching is not recommended. Patient typically experience minimal pain. Operatives to many patients notice pain relief, NSAIDs and opioid is not usually needed. Pain, dysmenorrhea, fever, foul smell, liquidia, it will be suspecting of some recurrent tissue residual component follow-up is 4 to 6 weeks after surgery. Complication after hysterectomy, generally overall risk complication is low. The most common intraoperative complication is the uterine. The most common complication is uterine perforation, hemorrhage, fluid cervical tear, laceration, fluid overload. These are the complications. Okay, let's talk about the steps in the myomectomy. Thorough abdominal and bimanual examination to do the size and position of the uterus. Funnel draping with outflow tubing connected to the canister for measurement of fluid deficit. For fluid deficit, you have to connect the funnel draping with outflow tract that is connected to the canister for measurement of the fluid deficit. Ask the anesthesiologist to calculate the mean arterial pressure to determine the initial hysteroscopy intravenous pressure to during the case. Set a fluid management system, alert the predetermined fluid deficit based on the solution using cardiopulmonary status of the patient. Grasp the surface with a single tooth cannulum. Inject dilute solution of vasopressin 20 units in 200 ml NS, 5 ml into cervical stoma at 11 to 7 o'clock population position. Then dilatation done with Hager's dilator using a half size dilator. If needed to accommodate the diameter, operative hysteroscope being used. Don't overdilate. Adjust the intravenous pressure or fluid management system as needed to maintain the clarity of the visualization, to maintain the protrusion. The above map is tamponade blood vessel to clear the debris. Place wire loop of the receptoscope behind the myoma and the electrode with the foot pedal. Activate the electrode with foot pedal. Move the hysteroscope separate towards the surgeon. Move the electrode long extrusion to cut larger tissue fragment. The cut fibroid was white whole appearance. The myometrial pink fascicle appearance of longitudinal white groups. Separate the slender connective bridge that join the fibroid to the adjacent myometrium. Intermittently lower and raise the intravenous pressure that will protrude the L2 and liquid the myoma. Monitor fluid absorption carefully to the case. More rapid fluid absorption occurs type 1 and type 2 myoma. Prolonged surgical procedure when visualization is hampered owing to tissue fragment. Halt the procedure, remove tissue fragment under the direct visualization with wire loop. Slowly retract the hysteroscope. Let the fragment tumble out to further removable tissue. The surgeon may need to remove the hysteroscope. Grasp blindly with polyforceps or Carson force grasper. This must be performed carefully to decrease the risk of uterine perforation. Reinsert the hysteroscope. Continue to resect until the procedure is completed. Maximum fluid deficit should be calculated. Maximum fluid occur like 1.5 in monopolar, bipolar, 2.5. Confirm the removal of tissue fragment if ability to decrease the post-operative cariadation bleeding. Okay. The post-operative complication like fever, severe unrelated abdominal pain, destination tenderness, increased complete shoulder pain, heavy bleeding with the change bad more than per hour, increased passage of clot, chest pain, shortness of breath, burning, urination, frequency, pentiness, passing foul, swelling, discharge with greenish yellow, unable to move bowel, 3 days, large water stall, diarrhea, blood loss. Uterine perforation is most commonly cervical dilatation. If midline perforation, how will you manage the perforation? If midline fundal perforation occurs, the patient may monitor for clinical symptom without further treatment. Okay, remember this fundal perforation, no need. Fundal perforation, no treatment. Only vital monitoring. If lateral perforation require a laparoscopy, we exclude uterine artery injury. If anterior and posterior require to evaluation of laparoscopy, bladder bowel injury, bladder and rectal injury, perforation with an electrosurgical device. If it is a electrosurgical device, then further evaluation the diagnostic laparoscopy and laparotomy to induce bowel injury. Excessive intraabdominal bleeding must be often caused by uterine perforation. Clinical evaluation necessary. If excessive diagnostic laparoscopy may require to suture the uterine defect. If uterine perforation is excluded, if there is no uterine perforation, but then diluted vasopressin should be injected intracervically and the patient should be monitored to decrease the blood loss. If there is no improvement, then intrauterine Polis catheter 12 to 24 hours to be placed and monitored. If slowly decompressed, then patient to be observed for recurrent bleeding. If severe uncontrolled hemorrhage occur, hysterectomy may be required. How you will manage the uterine perforation? If it is a fundal perforation, it is midline fundal, the patient should be monitored for clinical symptom without further treatment. If it is lateral perforation, it is require laparoscopy, exclude uterine artery injury. If it is anterior and posterior perforation, so bladder rectal injury has to be ruled out. Perforation with an electrosurgical device require. If it is perforation by electrosurgical device, you directly go with a diagnostic laparoscopy or laparotomy to prevent the bowel injury. If excessive intraabdominal bleeding is suspected, then you suspect it is uterine perforation. Then, if excessive diagnostic laparoscopy may be required to suture the uterine defect. If uterine perforation is excluded, then diluted injection vasopressin should be injected intracerebrally. Patient should be monitored. If there is no improvement, then again you polish catheter tamponade for 12 to 24 hours. Again, it is not compressed. Should again recurrent bleeding, then hysterectomy. Delayed complication include fever, the development of the intrauterine adhesion, endometritis, infertility. The development of post-operative adhesions has been reported 10% of patient may be increased women undergoing multiple hysteroscopy, myomectomy with the opposing fibroids, transmural treatment of uterine fibroid, patients with the urinary embolization, hypoestrogenic condition, post-operative hysteroscopy few weeks after surgery may be helpful to the treatment of implementation. Real complication, fever, endometritis, endometritis, infertility. The development of post-operative adhesion has been reported in 10% patient. So, maybe increase in women undergoing those women undergoing multiple hysteroscopy, myomectomy with opposing fibroid and transmural treatment of uterine fibroid. Patient treated with the urinary embolization. Those are hypoestrogen condition, post-operative hysterectomy. So, we will do a post-op hysteroscopy few weeks after surgery. That will help to treat the PMG adhesion.